we have Jens Lundgren from Sweden, who's someone that I've had the pleasure of doing a bit of work for before, and we've watched each other present, and it's a privilege, Jens, to have you on here. I'm just going to explain a little bit to the people watching about who you are.
Right.
Jens, you mentioned to me off air a second ago exactly what your title was, and I was about to have a go at it, but I think it's going to be better coming from you.
Yeah, that's true. It's actually called Doctor of Naturopathy. It's actually sometimes I cannot pronounce it myself either, so it's understandable. It's something that we have specifically in the Scandinavian countries. You can also find it in America, in North America. It's, I would say, the easiest way to explain what it is. It's that it's a mix between physiotherapy and chiropractic. So then it's a 5 years educational program before you get your license, and there's a big focus on manual medicine. That's basically it. So look at it as kind of physio-chiro mix, I would say.
Okay, good. Yeah. Sounds very interesting.
That's what I do. Yeah.
And the way that I would describe you is, I'm going to call you a physio for now because I can't pronounce it.
That's okay. That's okay.
With a very, very special interest in ultrasound imaging, and you've been working with Shockwave for, we'll come into how long you've been doing that in a second, but you combine these two things, the Shockwave and the ultrasound, very expertly. You teach all over Sweden, but in fact all over the world on these different techniques. So sometimes you might just be teaching ultrasound imaging, other times just Shockwave, but your real love, I think, is to bring those two things together. And
that's correct. Yeah.
I think we're fairly well aligned on how we like to use Shockwave, but we're going to use this period of time just to go through and find out, as we have done with some of the other interviews, a bit about you and a bit about your thoughts. But what the people watching this really want is some nuggets of how they might improve their Shockwave practice as well. So hopefully we're going to try and draw some of that out, so we really get an understanding of what's happening in Sweden and alike, and perhaps thinking a little bit, because there are lots of people that I speak to from the International Society of Medical Shockwave Treatment and professors who really, they don't want to use Shockwave unless they've got imaging in certain cases. And yet in primary healthcare settings in the UK, we would do a clinical diagnosis, and unless we had significant reason to suggest there was something horrible underlying, then I myself and many others besides wouldn't take the time and expense, frankly, to go off and get what is quite defensive medicine. It's seen as defensive medicine in this country, to constantly be scanning everything to make sure. But we might look into what we think the risks of that might be, and how ultrasound versus MRI or CT. But let's get to know you a little bit. How did you first come to be involved with Shockwave? What was your journey? Who introduced you to it first?
Yeah, the funny thing is that I was introduced to Shockwave therapy by ultrasound diagnostics. That's quite funny. And because I got the advice from some of the teachers at the school, at the university where I studied, to if you have a good knowledge in anatomy, then you're likely to be able to be a good diagnostician in ultrasound. And so I investigated this to see if what is the sensibility, specificity, and so on for ultrasonography. And I did a systematic review on the topic. And just as I published this, Stores Medicals, they also published their combined machine with an ultrasound included in the Shockwave setup. And that's when they invited me to lecture about this study I did about ultrasonography. And this is actually how I got into seriously working with the two methods. I was actually, on a very experimental base using Shockwave already, but this is when I really got involved and started lecturing on Shockwave and ultrasound, of course. So that's my journey to Shockwave.
Excellent. And in terms of how you use it in practice now, you see patients and you treat them. So in terms of a percentage, maybe how many of your patients would be scanned? How many of your patients would receive Shockwave on, let's say, a percentage basis over a day or a week? Or
well, I would actually say that all of them come for a scan because they are referred to my clinic because of my specialty in ultrasonography. So I see the patients. I have a question from someone else, or maybe in-house from my colleagues, and I do a scan. And then when I find suitable indications, I also propose shockwave therapy.
Yeah.
So that's basically how I do it.
And when you say suitable indications, what sort of indications are you driving at for Shockwave? Because the list seems to become bigger and bigger every day. We run the risk of saying that Shockwave cures everything. And so when you're scanning, what are the things that you go, right, in Sweden, what is considered a suitable indication?
Well, primarily it would be tendinopathy. So any kind of tendinopathy, that is what is sort of well accepted to work with shockwave therapy. But then, as you say, the indications start to really, you can treat almost anything. But I would say, since I have these situations where the patients are referred to me for diagnostics, then there's always a selection before they come to me. So most of the patients, they have a real sports medicine indication of any kind, and most of them would be tendinopathy. Then trigger points are, of course, involved in myofascial dysfunction. I try to look at the patient in a holistic way always. So that includes everything.
Yeah, no, precisely. And have you used imaging to look at kind of before and after in terms of tendinopathy? Like, do you find we get some vascularization? Are you seeing distinct changes, pre and post treatment?
Yeah, well, this is a tough question because it's really you would really like to be able to tell the patients that when you come back in 3 weeks, we will see some changes. But in most of the cases, when speaking about tendinopathy, you don't see it in this really short range. Tendon healing, people would probably, everybody, even professionals, when I ask them, what do you think is the average time for a tendon to fully heal? And then we look at it, the process in itself. Everybody tends to say too short. And I would say that using shockwaves, you can expect 3 to 6 months before you really see some changes in the healing process. Without shockwaves, maybe 6 to 12 months, even more, I would say. So the difference really that you can see with ultrasound, well, sometimes if you divide your tendons into early stages of tendinopathy, like a reactive tendon, then you can really see changes in a few weeks, no problems. But when we come into the phases of tendon disrepair and tendinosis, then this is irreversible, I would say. However, you can look at small details like the vascularity, and the vascularity change a lot faster. So you can actually see that the character of the vascularity changes between one session and another. But for the untrained eye, this would be impossible to see the difference. But I can see the character of, for example, an Achilles tendon, the vascularity will be in one way when it's more chronic or long-lasting pain syndromes. And then when the healing process is starting up, you can see that there is a more reactive vascularity, which is the sign of, okay, so now there's a healing process.
Yeah.
So these kinds of signs and prognostic factors that you can actually read from the ultrasound. Yeah. As a follow-up. Yeah.
So there's an interesting point actually surrounding the patients would love us, wouldn't they? They would absolutely love us to be in a position to go, here's a scan, here's your very unhappy tendon, and we're going to do this magic treatment, and then straight afterwards or a week later we're going to show you a scan where it all looks healthy and we could signpost it. And actually the naysayers, the term we use, the people that say Shockwave doesn't work and it has no efficacy, and they pull the science apart, I think that sometimes that leads into that. So, you're going to show me a development in 3 or 6 months. Well, is that not natural healing? Have they been doing their appropriate loading? So of course that's the reason it's not Shockwave. So we're dealing with that. So I guess my next point would be, what areas of research do you think would be really important going forwards for us now in order to bring more people into the Shockwave family almost?
Well, yeah, that's a tough question. I think, I sometimes put some cases on LinkedIn, and I get a lot of comments from orthopedic surgeons and other healthcare providers around the world saying that, can you show me these, double-blinded, placebo-controlled studies that actually supports what you're doing? And to be honest, there are studies like this, as you know, but to really increase the seriousness of the method, it would be nice to have more. Although it's a complicated question, because how do you do a really nice placebo-controlled study with shockwaves? And I generally pose the same question back to them when they ask me. A knee surgeon, how many placebo-controlled, double-blinded studies do you have supporting your ACL reconstructions? It's not ethical to do, and it's not possible to do placebo-controlled studies. In all cases. But I guess bigger population of the studies, of course, replication of the studies, that would be very interesting. And once again, if you could use imaging to really see the difference, and I'm sure that you could if you pose the questions in the right way, then that would also, of course, increase the seriousness of the method, I think.
Yeah, I did some stuff around osteoarthritis of the knee, and I put a lot of time in last year to working on this, and I actually used my own knee, and I did an MRI scan. Well, I had an MRI scan from 4 years previous when the consultant said, don't run and don't do this, and your knee is the age of an 85-year-old and all these horrible things. And I started a program with Shockwave, and then 4 years later, so this is a degenerate disease, so let's not image it too quickly. And after 4 years, all the bone marrow edema had gone. In terms of the speed at which my osteoarthritis appeared to be going, it had slowed to an almost stop, but obviously it's still there. Study of one, no one likes anecdotal stuff, but I would love to have the funding to do a large-scale study on osteoarthritis of the knee and actually get, annual MRI scans of these knees, but also to put us in a position where we could have a control group that were perhaps moving through having the MRI scans without the Shockwave. But to get people to believe in the things that we believe we're seeing in clinic, you would need 100 on each side at least, I think.
At least. So, it's a tough question, but then again, if you ask users and you ask anybody that I meet in the conferences and anybody that all patients, they're already very convinced. So to get the word out there is just to have also more of these kind of interviews like we are doing now, and symposiums where you get to discuss with users. Just to get more conferences, I would say. That's I think the biggest thing that is easily done quite fast.
And spread the knowledge. I mean, we have patients in my clinic who are coming in, they're going, oh my God, this is incredible, and then they want Shockwave on more areas because they've had this long-standing issue, their Achilles maybe. Suddenly they're, can you do this? My husband's coming in, all the friends are coming, and everyone's really happy. I mean, the success rates are huge, so it's an interesting point. So do you have one, perhaps not one you've written, but do you have one academic paper that you think has been a big game changer? Your favourite academic paper on Shockwave therapy? Questions. So, Jens, we're back again. Sorry for that delay.
Great. That's okay.
The key thing for us now is to get back onto that question. So, Jens, is there a key piece of evidence that or research that you've read which you think is a bit of a game changer for the people watching this that would really change the way they think about using shockwave?
Well, I think a very common indication, which I've actually read some articles quite recently. It's not brand new articles. One of them is from 2015, but for me it was quite new, and it's that carpal tunnel pain syndrome seems to be having quite great success when using shockwave therapy. As a matter of fact, I've started to collaborate more and more with a hand surgeon, and hence I get more patients referred to me with this problem. And it's actually a study which is double-blinded, placebo-controlled. It's quite small still, it's 40 participants, but they show really good results using pressure waves, radio pressure waves, for treating carpal tunnel pain syndrome. I've been using focus shockwave for this, and I have had so good results that I could not believe it. So it's been mostly women, but women with really pain that stops them from using their phone in the daytime, or working at a computer, or maybe carrying their children, and they have throbbing pain at all time. And by two treatments, or maybe 3 in some of the cases, the pain has gone from a 7 to a 2 or something like that, and it seems to be actually lasting. When I call them a few months later, they still don't have any problems, and they're not using their splints anymore. So this for me has been actually a game changer. But I mean, there's a lot of articles you can read. I would like to also say something else about this. Is not one article. This is actually a place where you can go, and this is the conference of ISMST, where a lot of researchers around the world gather to speak about shockwave therapy. This was an eye-opener for me, because in Sweden it's almost only physios and naprapaths like me, or chiropractors that are using shockwave therapy. But when you get to these conferences, you really meet the world, and you can see that it's such a hype. It's really everyone is using it in so many different fields that you could never imagine. And this is an eye-opener for me. So really try to go to any kind of international congress and learn from each other. This is the big eye-opener, I would say.
Yeah, we're really hoping that obviously it'll be going ahead in Vienna this year. Although big gatherings at the moment are being cancelled all around the world. I actually have my I have my hotel, I have my flights all booked for that. We'll just have to wait and see if it goes ahead. Interesting that you talk about carpal tunnel syndrome. Do you do injection therapy as well, Jens?
I do, yeah, I do.
So how do you find, because I also do injection therapy, and I find also using focus shockwave on carpal tunnel to be far superior to injection therapy, splinting and injection therapy, far superior. So much so that I would rarely actually reach for the needle. Instead, I would go straight to shockwave. I don't know how you feel about that as a statement.
Well, I mean, I always do that. I always recommend my patient, I have a simple way of doing it. If they're not doing proper exercise, this is the first step to get them into doing proper exercise. This is the least invasive you can do for the patient, and that will do them the best favor for the future. Long-lasting results. And then second step would be when this is not enough, or when they want to proceed faster, or they have more pressure as being athletes and so on, then I introduce shockwave as well. And if this fails, which rarely actually is the case, then I go further to more invasive methods like corticosteroids or PRP injections and so on. So in most cases, this is the way I work, actually.
The trajectory of
it. And just like you say,
it's really few cases when injections would be the first choice.
Yeah.
Yeah.
So talking about different modalities, when I teach, I talk now, and you obviously do the same from hearing you speak today, is you talk about radial pressure waves and you talk about focus shock waves. So when I'm teaching people in the UK in particular, but around the world, people are calling shockwave, and what they're actually holding in their hand is a radial pressure wave, which we always used to refer to as radial shockwave, which becomes quite confusing because it's all about the inflection point. So in order to get an actual shockwave, you only get that from the focus machine. The pressure wave actually has a pressure wave. So we know from science in many cases some similar results.
Yeah.
The pressure wave, by very definition, when its highest pressure is at the surface, that's going to be more superficial. A shock wave, the element of the treatment, the highest point of the treatment is actually deeper, so it's easier on the skin surface. So we're really trying hard to get people to understand that both are therapeutic modalities, but they actually work in different ways. I tend to really enjoy using my radial pressure wave on the surrounding tissues and the focus shock wave on the actual area that is most painful and from your imaging or from your diagnosis would be the area where the opathy or whatever it might be is. So it's a tough question to ask, but if I from this day forward was somehow in control of Jens Lundgren, then and I could only give you one machine, the radial or the focused, which one would you choose?
Well, I would choose the focused. That would be an easy choice for me because I look at the focused as a device where you can be more specific. You can hit the target easier. You can. For me, it's more suitable for the pathology, just like you said, and the pressure waves are more suitable for the surrounding soft tissues. But the thing is that I cannot, with my hands, do what the focus does with pathology, but I can in some way do what the radial pressure waves does with trigger points and fascia by using my hands.
Yeah.
So this would be an easy choice for me, but then economy is one question as well, which is likely to change my options if it gets to that. But yeah.
They did a study out in Beijing last year when we had the ISMST conference, where they questioned everybody, how long have you been using shockwave and what do you use? Do you use radial or do you use focus the most? And anybody in the first year of using shockwave was using a radial pressure wave machine, pretty much 80%, I think. And then after that, it was predominantly focused. I'm starting to get a disc full on this machine now as well. So, Jens, what we'll do is to save all of my memory, I'm going to jump ahead to the last couple of questions, see if we can get it done. So,
right.
What advice would you give to people? 3 bullet point, fast-paced things. What advice would you give to somebody who's using shockwave right now? The 3 key Jens points.
Well, the first point would be I get in the audiences when I lecture, like the philosophy of some of the users is that there are either like people who are responders to shockwave or are non-responders, and this doesn't exist in my world. What exists is good indication for shockwave therapy and not so good indications. So first step would be to be sure about your diagnosis, and if you have the good indications, then shockwave works. The results are so good, but if you are a little bit unsure about your diagnosis and diagnostics as a clinician, then use your contacts to get an ultrasound or to get an MRI when needed, just to be sure that you have a good indication. That's a way to assure yourself that your results will be splendid at the end.
Yeah.
So that would be really the first point. Then the second point would be to individualize every protocol. So look at the patient you have ahead of you, and don't look at presets like saying that for an Achilles you should use this energy and this amount of shocks. Speak to the patient. Communication is really key. If you give it a vast scale between 0 and 10, I would say try to stay around 5 on this scale, and then you look at your machine and you say, oh, so I used 0.15 millijoules per square millimeter, or maybe I used 1.6 or 2 bars or something like that. Not the other way around. Use your patient and communicate.
I agree.
Yeah. So this would be the same when it comes to frequency as well, because frequency is a tough question. There's so many different settings in studies, but you can use the frequency in a way of changing the comfort for the patient. So if you use a low frequency, they will feel each hit more obvious, and if you use a high frequency, it will be more a continuum of stimulation, and then also less painful. So this is how I use frequency. When I look for the specific pain points, I use a lower frequency because it's easier to find the pain points. And then when I try to just get the energy into the body and get a reaction, then I can actually increase the frequency a little bit. So this is also something that you need to be really flexible about. Don't use protocols. Use your brain and use your communication with the patient. That is my.
I couldn't agree more. It's music to my ears. The one interesting point that I'd not thought of is using a lower frequency to actually search for the areas of pain. So that's brilliant. My disc is giving me grief now. So, but before we sign off, then very quickly. Is there something that we could get to know about Jens? What is the thing that outside of treating patients? What's your big thing that you love and enjoy doing?
Well, I have 2 kids, so obviously, this is really a big thing about my life at the moment. And but otherwise, I'm really outdoorsy, you can say. I do surfing, climbing, skiing. I run in the forest. I try to do mountain biking, trail biking, and so on. So that would be me, I would say. If I would try to give people an image of who I am, I would speak about the love of the nature, and so on.
It's so very Scandinavian. It's so very Scandinavian.
Yeah, very Scandinavian. Yeah.
And my last question, I ask every guest, what is the number one thing on your bucket list?
Oh, I have so many things, but maybe it would be to go to Japan and do some really nice powder skiing. That would be on the top of the list.
In which case, if I was a better skier, I'd say I'd come with you. But there are some in the Shockwave community. There's some very, very good skiers, so we could hook you up.
Yeah.
Jens, well, I think this has been brilliant for me and hopefully for everyone else.
Yeah.
So we're going to wrap it up by saying thank you ever so much. I'm sorry about the technical issues we've had. We've been through 2 Mac computers and we've filled up their memory. So
and 2 headsets.
And 2 headsets. But I know that you're daddy daycare today as well. So I thank you so much for taking the time. And I really am looking forward to doing some collaborations with you in the future. And we should get an academic study going between here and Sweden, and at least an excuse to visit more.
Yeah, that's a good reason. You're very welcome whenever you want to come to Sweden.
As in you to England, mate. So thanks very much. All right.
Okay. Thanks.
Well, look, you take care. Enjoy the rest of your day, and speak soon.
Okay. Bye.
Bye now.